Our first speaker today is Dr. Katherine Kendjorsky. She earned her medical degree from Ohio University, the Heritage College of Osteopathic Medicine. She has completed her residency in internal medicine at Riverside Methodist Hospital before pursuing her fellowship in endocrinology at the University of Kentucky in Lexington. Since 2018, Dr. Kendjorsky has been practicing as an endocrinologist with Ohio Health Physician Group. She works at both the Worthington and the Grandview locations. She's one of 6 partners within her practice, and she also serves as an inpatient endocrinologist at Riverside Methodist Hospital. Beyond her medical career, Dr. Kendjorsky cherishes time with her husband and her 3 children. Above all, she really loves being a mom. So we're so grateful to have you here today. We'll get it kicked off with her presentation.
All right. I have a height deficiency. So, can you hear me? We're good? Good. Okay. Thanks for the introduction. I'm really happy to be here today with everyone. I'm really excited about this. Diabetes is my passion. I'm an endocrinologist, so how many people know what an endocrinologist is? Good. Okay, everybody. That's a start. That's good. So endocrinologist is a hormone doctor. You might say, why is a hormone doctor talking to me about diabetes? And that's because we're going to talk about insulin as a hormone. So let's get started. So your journey with diabetes. I love the title of my talk because it really is your journey with diabetes. It's not my journey with diabetes, it's your journey. So I tell my patients, I know a lot about diabetes, but I can't go home with you. So I'm going to give you some tools in my talk for you to really advocate for yourself, to ask questions to your doctor. So hopefully we all learned something today, and we're going to have a panel at the end, like they said. So keep your questions for then, but if you have a really dire question during the presentation, I'd be happy to answer it. Okay? So let's get started. I have no disclosures. Other than I do like being a mom. So objectives today. This is very overwhelming. So it's going to be, I want you to think about today like being in the office with me. So think about this as like a free consultation with an endocrinologist. But we're going to cover what diabetes is. We're going to cover prevention, which includes lifestyle intervention. We're going to talk a bit about diet. We're going to get a good exercise introduction next. So I'm going to talk to you a little bit about exercise, stress reduction, and sleep. Checking your blood sugars is also a topic of discussion. We're going to talk about medications very briefly, and then complications of diabetes that we're going to try to prevent. All right, so what is diabetes? So diabetes, like I said, there are 2 types. So there's type 1 diabetes, which means that your pancreas does not make insulin. And then type 2 diabetes means you're resistant to the insulin that it makes. So the next slide, again, overwhelming slide. So when we take in food, we take food through our mouth. It goes down to our stomach. Our pancreas, which sits right in a little nook between our stomach and our small intestine, that's what makes insulin. So when you take in food, that gets broken down into sugar. Your pancreas then releases insulin. And then your glucose, your sugar, and your insulin travel through your bloodstream. The whole premise behind diabetes is that you have to have enough insulin to go out there and get the sugar so you can use it in your cells. And when you have type 1 diabetes, your pancreas doesn't make that insulin. And with type 2 diabetes, you still make insulin. Your pancreas is still making the insulin. You're just resistant to the insulin that it makes. And so we're going to focus a lot of our discussion today around type 2 diabetes and prevention, but it is applicable to type 1 diabetes too. These slides are very overwhelming. I'm going to share them. They'll be available online too for you to learn about, but it just shows some pictures of everything I just said. So again, type 2 diabetes means that your body still makes it, you just are resistant to it and can't use it like you should, and so you need more of it to bring down your blood sugars. Anyone can develop type 2 diabetes. We're actually seeing type 2 diabetes with earlier and earlier. So little kids in their teens, early 20s. There used to be a thought that type 2 diabetes was a disease of older individuals, meaning after the age of 45, which it still stands true, but we are seeing it earlier and earlier. It accounts for about 90 to 95% of diabetes, and that's true. About 10% of the population has type 1 diabetes. The risk factors are really what I want to focus on this slide. So there's 4 main risk factors for type 2 diabetes. Being overweight, having a family history of diabetes, inactivity, and being over the age of 45. I want you to really look at those risk factors again, because 2 of the risk factors are what we call non-modifiable risk factors. You cannot change your genetics. We can't. We can't change our genetics, and we can't change our age. So those 2 are non-modifiable risk factors. The other 2 risk factors being physically inactive and obesity, those are the things that you have the power to change as the patient. And I think that if we really focus on those 2 risk factors, we won't develop diabetes, and you'll be able to reverse your diabetes too. So again, a lot of this discussion is how you can be your own advocate and how you can help to manage your diabetes with exercise and diet, so you don't have to take medications. Medications are great, by the way, to help. I'm not saying anything bad about medicine today, but we need to understand how we can use medications and use diet and exercise. So how do we diagnose diabetes? How many are familiar with an A1C level? Oh my gosh, that's wonderful. Some people come to clinic and are like, I have no idea what you're talking about. So that's good. So an A1C level is a 3-month average of our sugars. The reason that we can check it every 3 months is that sugar molecules are attached to the red blood cell. Red blood cells are like little round particles in your blood, of course. And you have sugar molecules attached to it. So the more sugar on the red blood cell, the higher the A1C. The less sugar on the red blood cell, the lower the A1C. And the next slide is going to kind of show you. So a normal A1C is a blood sugar, or a normal A1C is less than 5.7. From 5.7 to 6.5, that's the pre-diabetic state. And then anything over 6.5 is considered diabetes. You might say, well, how do I know where I'm supposed to be along this spectrum? So that's between you and your doctor, really. There is evidence, and we follow the A1C of less than 7. So you get diagnosed. How are we going to treat you? We want that A1C less than 7. Ideally less than 6.5 in some patients. And you might say, well, why some patients 6.5? Why some patients 7? Or my doctor told me 7.5. So early in diabetes, we want the blood sugars really tightly controlled to prevent complications, which we're going to talk about later on. As we age, though, we don't need that tight control. I have patients in their 70s or 80s, and I worry more about low blood sugars than high blood sugars in them, because a low blood sugar in some patients can be just as bad as a really high blood sugar. So ideally less than 7, but that's a discussion to have with your doctor. So if they say, oh, your A1C's 7.5, you're doing well, say, okay, why is that a good A1C for me and my diabetes? Okay, so ask that question. What's my goal? Don't just go to your appointments and say, oh, they said it was 8.1, I guess that's good enough. Always ask the why behind it. So hopefully you understand A1C a little bit better after this. This slide, again, is overwhelming, but I just want to point out your A1C, to me, translates to an average sugar. So like if you look on the chart, an A1C of 7 gives you an average blood sugar of 154. And we'll talk about blood sugar goals in a few more slides. But it's nice to know, okay, so if I have an A1C of 7, that means my blood sugar is around 150 all the time. I think that's a bit too high. Maybe I should have my A1C around a 6.5. That would give my average sugar in the morning of less than 140. So that's just to kind of show you what we talk about. This slide kind of depicts, there's a lot going on in this slide. The picture up top is a freeway in LA, and the picture at the bottom is like a nice countryside with one road. Okay, nice and relaxing. Your journey with diabetes can be a freeway in LA or it can be a countryside drive. We just have to pick which roadway we're going to be on. Sometimes it's going to feel like you're in LA all the time trying to switch over 7 lanes of traffic. But our goal is for you to get your own path with your diabetes and have one way and make it as smooth as we can. So you get diagnosed with diabetes, what do we do now? We always ask questions. You as the patient, I want you to talk to your doctor. I want you to get a diabetic educator. We have wonderful ones at McConnell. I refer to them all the time. I think that you have to get tools in your toolbox to help with your diabetes. Talk with your family and friends about it. Sometimes there's a lot of shame. Some patients say, like, when they got diagnosed with diabetes, there was a lot of shame behind it. There's nothing to be, shamed about. You have 2 modifiable risk factors, you have 2 non-modifiable risk factors. Sometimes you cannot help if you develop type 2 diabetes. I get really frustrated because some people they kind of ignore their diabetes. By the time they get to me, they have complications because they were so afraid to admit that they had diabetes. I like to tell my story really quick about the time I was diagnosed with diabetes during pregnancy. And as an endocrinologist, you're like, oh, I don't want to have diabetes. I know all the things to do. And my partner in clinic, one of the other doctors, was sitting next to me, and the nurse from my OB's office calls, and she says, you have gestational diabetes. You failed your glucose test. And I had just eaten those little Reese cups, about 8 of them, okay, for lunch. It was a very shameful day. I was in my first trimester, I was like more than my second trimester of pregnancy at that point. But anyway, my sugar was 220. I really failed it. So I knew during pregnancy, if I didn't want to be on insulin, I had to cut the carbs. And I did. I successfully made it. Had a healthy baby boy at the end. I wore a continuous glucose monitor. I still do. But my risk for type 2 diabetes is ongoing. So, was I ashamed? I was ashamed at first. I thought, oh my gosh, how can I have diabetes? I know all these things to do. But I did. So it can happen to anybody. Don't be ashamed. You have to take control of it. You can't ignore it. Okay. So things we're going to talk about: early prevention and early diagnosis. So we're going to talk about diet changes, exercise, stress, and sleep in the following slide. So let's start with diet. This is a diabetes plate. How many people know what a diabetes plate is? Okay, gosh, you guys are so good. You already know all of this. So a diabetes plate is a 9-inch plate. That's the model that we use. I should have brought one. I don't have one. It's not like the platter that they give you at the restaurant these days, okay? Like here's your food for how many people? That's too big, okay? So get a 9-inch plate at home. The plate controls your portion, and it's all about portion control. So on the green half of the plate, you have your vegetables, and we're going to talk all about vegetables. I laugh because people are like, I hate vegetables. I'm like, well, you got to taste them. You just got to try it for me. Carbs, 1/4 of your plate is carbohydrate, and 1/4 is protein, okay? So let's talk about the non-starchy vegetables. These are the basics. You have to fill half of your plate with these non-starchy vegetables. You can choose to, I should say. I recommend it. But the basic ones are like carrots, spinach, peppers, cucumbers, cauliflower, onion. I'm not expecting you to eat like onions, maybe mix it in the salad that you're going to make. But non-starchy vegetables. So fill up on that first, and then move to the rest of your meal. Let's go to protein. Protein is a big thing. So you're thinking about like chicken, turkey, fish, if you like fish. Tofu is on there, cottage cheese. So you want a little 1/4 of your plate to be protein. Some protein, like plant-based proteins, can be beans and lentils, hummus, falafel, and nuts. So you want to have a good portion of that protein, 1/4 of your plate. And then 1/4 of your plate is carbohydrate-rich foods. You might say, well, why are you telling me to eat carbs when I have diabetes? That'll make my sugar go up. But 1/4 of it. So I say, and the dietitians in the room can correct me if I'm wrong, but I kind of go by the 1 carb group per meal. So 1 cup. Rice, pasta, potato, that is it. That's your 1/4 on your plate. You get a cup, a measuring cup, that's what you can have. That includes your bread, your rice, your pasta, a tortilla, a slice of bread, a starchy vegetable like peas or carrots, plantains, pumpkin is in there, some squash. So that's 1/4 of your plate. That's not half of your plate. So that part of it is designated for your carbohydrate. That includes your fruit. If you want fruit with your meal, you have to include that in your 1/4 of your plate. So I say fruits. I often get questions. Some patients will say, Well, I thought fruits were good for you. And it depends on what type of fruit it is. So you got to watch your melons. So, honeydew, cantaloupe, watermelon, they will make your sugars go up. They have a high sugar content. So berries are your friends. Blackberries, blueberries, strawberries, in proportion to that part of your plate, okay? I included this on here against my better judgment, but yogurt and milk are also included in there. And in my next slide, you'll see what I mean by that. So these are my pearls. This is what I tell my patients in clinic. I have a couple patients, and one of my special diabetes patients is in the room, and she's heard me say this before, all my pearls. But you have a 9-inch plate. That's one. When eating out, eat half of your meal. So if you go out with friends, you get your meal. Take half of the meal right when it gets to you, put the other half in a box, or share it with somebody. Like I said, they serve us on platters at restaurants now, so take half of the meal. Berries are your friends. I still will always believe that. Berries can be snacks. You can have berries and cheese, nuts. All of that is a snack. Download, if you have phones, everybody has a smartphone, you should download an app on your phone. I'm not saying you have to carbohydrate count, but there's a few apps that I like. One is called Calorie King. There's one called MyFitnessPal and the Lose It app. The Calorie King app is nice because it will give you a food label and it'll show you the total calories, but it also shows total carb and fiber. So it gives you an idea. You can press anything in there, like, oh, I don't know, this certain type of bread, how many carbs are in it, and it'll tell you. So I tell patients, milk is not a drink for patients with diabetes. I think I'm going to be debated on this, but don't drink your calories and your carbs. If you want milk, you have to include it as part of your plate. You have to include it in your carb count. Milk will spike your blood sugar. It doesn't really matter what type of milk it is. Water. Everybody could use a little more water in their life. So make sure you're drinking throughout the day. If you eat, you should be having a glass of water. If you're in between breakfast and lunch, you should be having a glass of water. And then everything in moderation. So it's my birthday next week. I am going to eat cake on my birthday. And I tell patients, if it's your birthday, have the cake. Just don't check your blood sugars. No, I'm kidding. Check your sugar. But have everything in moderation. So, if it's a Christmas or Thanksgiving, you can still have a treat. Just don't extend the holidays. So we extend holidays over months, which I love the holidays. But you can have your day. I want you to live. I want you to enjoy good food. You can have treats. Just what is in it and everything in moderation. And then how does food make you feel? This is I love this piece of advice I can give to patients, and it sounds really weird, but if you eat lunch, 2 hours after lunch, think to yourself, how do I feel? Do I feel sluggish? If the answer is yes, that food is not good for you. Whatever you just ate, don't eat it again. Because food should make you feel good. You should feel energized after you eat. You shouldn't feel sluggish. So think to a time when maybe before you heard me talk, you had a big thing of pasta. How did you feel 2 hours after that? You probably wanted to take a nap and you were probably hungry. So use food as a fuel. Don't use it as something to bring you down. And then what's your relationship with food? So again, another weird thing to think about. You're like, why does she care about all this food? But why are you eating? Do you eat because you're sad? Do you eat because you're angry? Do you eat because you're celebrating? I do. Why are you eating? And you have to figure out the why behind it. Are you bored? Do you work from home? I feel like working from home is a blessing and a curse sometimes because you get trapped on that computer for 8 hours. You're not up moving around. You're snacking. So think about your relationship with food. And then also, like, let's say you eat dinner. After dinner, 2 hours after dinner, are you hungry or are you thirsty? Did you drink enough throughout the day? So if you're asking yourself, I just ate, why do I feel hungry? You're not hungry, you're thirsty. So drink your water, take 15 minutes and say, oh, I wasn't really hungry, I was probably thirsty. So those are some pearls to take home. Again, these slides will be available if you want to go back and read through them. Exercise. So I would make everybody put up their hand for exercise, but I don't think I'm allowed to do that. You don't have to. But exercise is so important. 150 minutes is recommended by the American Diabetes Association per week. Patients laugh when I say, are you going to exercise? And they say, when? And I say, whenever you can. You don't have to go to the gym. You just have to move your body. That's, I think, one thing. Again, sometimes the shame of like, I haven't worked out in years. I don't even know where to begin. Like, she's telling me to work out. How am I ever going to do that? You just have to move. You got to start somewhere. Everybody starts somewhere. They're lying if they say they didn't. So just move, okay? One of the things is, everything's electronic now. So sometimes I tell patients, okay, they get worried. Like, I started to move and then I missed a few days and I got off track and then I stopped for 3 months. If you want to keep track of your exercise, don't put a lot of pressure on yourself. Just get a calendar. Put a little check mark if you exercised. At the end of the month, if you exercised more than half of the days of the month, you did good. Okay, so that's 15. There's 30 days in a month sometimes. You exercise 15 days, you did really good. Okay, so think about it like that. Don't make it too complicated. If you want to start out exercising, 2 10-minute walks a day is a good goal. You take a little walk in the morning, that's 10 minutes. And it has to be intentional exercise. So if you go to the grocery store and you park far away, okay, I would include that. But I really want you to take that 10 minutes a day for yourself, too, to kind of decompress and take your walk. Again, you don't have to go to the gym. Recruit a friend. Everybody loves to recruit a friend unless they're like an annoying friend that would be really annoying when you exercise with. But sometimes we do best in pairs. So YouTube videos are great for exercise. There's a lot out there. There's I don't get any paid to say this, but there's a YouTube yoga by Adrienne is a great one. She has like thousands of YouTube videos. Light weights at home. You don't need those bands or anything. You just need to start lifting some weights. And then chair exercises count. So everybody starts somewhere. So get a chair and start exercising. Start slow. Warming up and cooling down is very important too. 5-minute warm up or cool down when you get into it. Obviously, don't exercise when it's really hot outside or really cold outside. Stay hydrated. If you are on a medication where you feel like you would lower your blood sugar during exercise, like insulin, there's some other pill medications that can lower blood sugar during exercise, and you feel it coming on, stop your exercise. Do not keep exercising until you've treated that low blood sugar. The easiest thing to treat low blood sugar is a juice box. So just take one to the gym with you, along with your water bottle, and if you're feeling a low, go ahead and sip it. Wear a medical identification bracelet. So if you start a new exercise regimen and you come to the gym or go to a gym or you're outside walking, someone has to know that you have diabetes. So if it's a bracelet, a necklace, if it's an app on your phone, there's iPhones that have health apps, and you can put like, I have type 1 diabetes or I have type 2 diabetes, I require insulin. If you find me, I might have a low sugar. Sometimes we get patients in the hospital that are combative and they get brought in for different reasons, and actually they're having a low sugar. So I don't want that to happen to you. Benefits of exercise. Overall, it'll make you feel better. It'll make you happier, I promise. Just moving your body will make you happy. It helps to lower your blood sugar. So in the beginning when I was talking about insulin resistance, it actually puts more insulin receptors on the cell surface. So walking, exercise is like natural insulin. It'll help to bring your blood sugars down because it makes you more sensitive to insulin. It gives you more energy. It helps with mobility, and it lowers the risk of heart attack and stroke. So exercise is great. I think hopefully we start. I guess I had one more slide. I didn't really. If you feel like, okay, I'm starting to exercise, I don't know if I'm overdoing it, there's something called the talk test. And so you're exercising. If you can still talk when you're exercising, it's not too strenuous for you. If you feel like, oh, I can't talk if I were to take a walk with my friends, slow it down. When you're first starting out, you don't want to overdo it. Patients with diabetes, we talk about taking care of your feet. Make sure you get a good pair of shoes. Make sure you wear socks. And make sure you look at your feet. I know it sounds really silly, but it's so important. And then, of course, stop exercising if you feel pain or shortness of breath or feel lightheaded. Take a break, okay? Don't pass out. This slide just talks about sometimes how many of you exercise and notice your sugars go up? Does anybody? Oh, good. Okay. Do you know why? Does anybody talk to you about why? Okay. So adrenaline, which is a stress hormone that's released when we exercise, can elevate blood sugar. So you might say, oh, you just said it will lower my sugar. But some exercises like weightlifting or competitive sports, your adrenaline is going, so your sugar is going to elevate. So also what you eat before exercising can elevate your sugars. So how to get around that is to warm up and to cool down. That will help prevent that spike in sugar while you're exercising. Relaxation during exercise. I know it sounds weird, but watch your breath. Kind of practice your breath work while you exercise. That'll help to lower your sugars. There is something in diabetes called the dawn phenomenon. It's when you wake up and your sugars start to go up and you're like, I just opened my eyes, I don't know why my sugar's going up, and we're going to talk about that in a minute. But that can happen in the morning. So in patients that have this elevation in sugar in the morning, I tell them try to wait till later in the day to exercise so your sugar doesn't spike as high, and then avoid eating a lot of carbs before you exercise if you can. All right, stress reduction. This is a good one. Sometimes patients roll their eyes. I feel like I say that a lot. Sometimes I suggest things and people roll their eyes. But I feel like it's because how are we going to fit all this into my day? It sounds like a lot. She wants me to exercise. She wants me to eat well. Now she's talking to me about reducing my stress. These are things that you can do over time. It doesn't have to be, you pick one thing, you start slow. So reducing your stress. Everybody's on a screen. I'm on a screen all the time. I'm in front of a computer, I'm talking to patients, I'm on my phone at night. We got to put the screens down. There's a correlation between our obesity rate and the use of screens. You're on a screen, we're not moving. So put your screens down because it stresses us out too. The news stresses us out. Social media stresses us out. So unless you have to be on it, put it down, and your blood pressure will probably drop along with your sugar. So exercise is a great way to reduce stress. And then most of all, throughout all of this is to do things that you enjoy. So if you enjoy painting, if you enjoy sports, if you enjoy spending time with your family or friends, do something that brings you joy every day. And that will help to reduce your stress, and that will help to reduce your blood sugars and your blood pressure. So the last three things on here, meditation and yoga, I pair those together. Patients are like, you want me to close my eyes and just sit there? Yes. So meditation does help to lower blood sugar, and it helps to reduce stress levels because it helps to reduce stress hormones. If you've never meditated before, there's an app for that. As I say, put your screens down. But if you find there's 5-minute meditations, but really meditating, when you really get into it, there's a lot to it, but really meditating is just sitting quietly and kind of letting everything go, and really focusing on your breath and making sure that you're just present in the moment. We're really fast paced, and all of this can elevate our blood pressure and our blood sugar, which leads to increased rates of obesity too. Sleep. So sleep is really important. How many people get 6 to 8 hours of sleep? Oh, good. There are people who sleep. I love it. So sleep is restorative. It helps to lower your morning sugars. It helps to, helps immune health too. It helps to reduce stress. So sleep is often underestimated, and actually patients who come into clinic, and we're going to get to this in a little bit, we talk about sleep. How did you sleep the night before? Why are your sugars high? Some people who work long hours, they'll be on vacation and they'll see me one week and they're on vacation. I'll be looking at their sugars. I said, you're on vacation this week. They say, how do I know? I said, because you're sleeping. I can see your average sugar is down 20 points. So sleep really helps. And then patients with type 2 diabetes should be screened for sleep apnea. Even if you don't gasp for your breath when you sleep, if you're snoring, if you're tired in the afternoons, treating sleep apnea actually helps to lower the sugar too. So ask your doctor. They're probably going to kill me for saying it, but ask them. No, you need to be screened for sleep apnea to make sure that that's not a cause for why your sugars may be higher in the morning. All right. Now, monitoring your blood sugar. How many people have a continuous glucose monitor? Okay, good. That's good. How many people still poke their fingers? Okay, like half and half. Okay, so this is probably stuff that you already know. But why do we want you to monitor your sugars? Why do we care? We care because we have you on medications for diabetes, or we care because we're trying to get you to modify behaviors. So what do I mean by behavior modification? It kind of sounds like I'm blaming you for something, and sometimes I write that in my note, and patients are like, "Oh my gosh, you're blaming me. What do you mean behavior modifications?" Behavior modifications just means to give you information to help you modify what you did before. And we're going to talk about that in the next few slides. And then medication management, well, I want to know what your sugars are. I can't adjust your insulin if I don't know what your blood sugars are. I can't recommend a certain medication if I don't know what your sugars are doing. So what do you need to check your sugars? This is probably repetitive for a lot of you, so I'm sorry. But you need a meter, you need alcohol swabs, you need lancets, and test strips. So these are just some common meters. There's Trumetrics or One Touch, AccuCheck, Freestyle. I want to point out the last two. Rely On is a brand from Walmart. It is cheap. You don't have to use your insurance. And then a Kroger meter too. The cheaper ones, the Rely On and the Kroger, are just as good as the commercial ones. So if you say, I can't check my sugar because my insurance doesn't pay for it, I'm having trouble, go to Kroger or go to Walmart and you can get a cheap meter there. It's just as good as these other ones. And then lancets, everybody probably knows what a lancet is, but some people don't know what I'm talking about. So the top two pictures are a lancing device. That's the thing that's used to poke your finger and get the blood out. There's certain settings on a lancing device. Some patients are surprised by this. That's why I pointed out. They go 1 through 7. So the higher and the lower setting, that's how it's going to pierce you for you to get your blood out of your finger. The bottom left picture is a picture of lancets. Those are the colored things that you put on the actual needles to poke your finger. And then the last picture is basically it's called a lancet drum. It's just a drum that holds like 5 lancets, and it's a clicking device. So you fill it in the morning, and you'll be able to use that lancing device all day. So I show you all of this to say there's lots of different lancing devices out there. Sometimes it's what your insurance will pay for. Sometimes it's what you want. So if you get stuck with a lancing device, you're like, oh my gosh, it's hurting my finger all the time. That's why I'm not checking my sugar. Ask for a different one. So there are other ones out there. Test strips, everybody probably knows what a test strip is. They come in those little containers in 50, 100. That's pretty self-explanatory. So how do I check my sugar? Number 1, wash your hands. Sometimes I'll get called on call overnight, and it's like, I'm getting ready to eat dinner. I ate it. I went to bed. I checked my sugar before bed. It was 200. I have no idea why. I said, did you wash your hands? No. Go wash your hands while I'm on the phone with you, and then recheck, and it's lower. It's because things can get on your hands that falsely elevate your blood sugar reading. So if you get a reading, you're like, I don't know about this. It's too high. Wash your hands. So wash your hands, turn on your glucometer, put the test strip in, and then prick your finger. And the next picture is you just place a little drop of blood on the test strip, and then make sure you wipe the blood away. So that's the traditional self-glucose monitoring. And now we have these fancy continuous glucose monitors. I wish that everybody could get a continuous glucose monitor because it's so nice. So it is what it is. It continuously monitors your sugar. There's 2 types that I use in clinic. One is called a Dexcom, and the other one is called a Libre. How many people know Dexcom? How many people use a Libre? We're like split 50-50 in this room. So Libre can last 14 to 15 days. It's a little patch that you wear on your arm. The upper left picture shows you a Libre device. It's about the size of a penny. It's very thin, and you can see on the second picture that little part sticking out. It's not a needle. It's a little catheter that goes underneath the skin. That little catheter does not measure the blood. It measures the interstitial fluid around it. So it's different. So you use blood when you prick your finger and get it on your test strips. The continuous glucose monitor looks at the interstitial fluid in your body. So it's a different way of monitoring. The continuous glucose monitor monitors your sugars every 5 to 7 minutes. Again, Libre, it can last 14 to 15 days, and Dexcom's good for 10 days. You got to take it off and put a new one back on. I had a YouTube video for you, and it doesn't work. So we're gonna, at the end on the panel, my sister, who is here today in the room, she's gonna be my guinea pig, and I'm gonna put one on her so we can see it in real time. Ohio Health won't let me use you as my guinea pig. I think it's a liability. So sorry, I had to invite her, so I'm gonna put one on her and to show you. But you don't have to stick around for it if you don't want to see it in real time, since you already have them, some of you. All right. The thing about continuous glucose monitoring, it does look at that interstitial fluid. So you can get false high and false low readings. It's allowed to vary, and it can vary up to 30 to 50 points, which is a big deal in some folks on insulin. So if you're getting a really high reading or a really low reading, you're like, this is not right, and you check your finger stick, know that you have to always go by your finger stick blood sugar, okay? These can vary. Sometimes the sensors are bad. If you call the company, they will send you new ones. Compression lows, has anyone heard of a compression low? Okay, good. So compression lows are if you're sleeping on the sensor at night and that little catheter gets compressed down, it will give you a low reading. Your blood sugars are not 40 all night long. It's just a compression low. So roll over, it'll come up, but compression lows happen. Sometimes the adhesive on there can be pretty harsh to the skin and cause a rash. You can get away with a rash. Flonase, the stuff that you stick up your nose for allergies. Dexcom says you can put that on your arm. So spray some Flonase on your arm, let it dry, and then put your sensor on, and that helps with the rash from the adhesive around it. There's overlay patches that you can stick if the adhesive is falling off. There's overlay patches called Skin Grip. There's some on Amazon that can help the sensors to stick on better. Always double check your continuous glucose monitor with a finger stick. Okay, this looks very unprofessional, but you're in the clinic with me today, and this is what I draw out for my patients. So I drew it out for you. You're so lucky. Again, it's a depiction of, if you look all the way, so it's your far left, pre-breakfast, lunch, dinner, bedtime. So we're going to talk about blood glucose goals. Your pre-breakfast blood sugar should be between 80 and 130. Before lunch, less than 140. Before dinner, less than 140. After a meal, your sugar really shouldn't go any higher than 180. So I want you to kind of take this slide in, and I'm going to keep showing you throughout the next few slides, because we're going to talk about what to do once you have your finger sticks, once you have your continuous glucose monitor, how at home you can decide, what to do with my medication. So what affects your blood sugars? What's going to affect these readings? And the answer to that is absolutely everything. You could do the same thing every day and you're going to get different sugars, because how you slept the night before is going to affect your sugar. What you ate for dinner the night before is going to affect your morning sugar. What your sugar was at bedtime is going to affect your morning sugar. If you took insulin at bedtime, that will affect your morning sugar. If you drink coffee in the morning, even without cream or sugar, and let's say you drink your coffee, then you check your sugar, coffee, the caffeine is just it's gonna elevate your sugar. And then the dawn phenomenon, what I was talking about earlier, when you start to wake up, your stress hormones go up, your wake up hormones called cortisol, those are highest in the morning. So you might say, I'm laying in bed and my sugar's 130. I get up and take a shower and it's 210. What the heck happened? That's dawn phenomenon. That means those stress hormones are just elevating your sugar, and you'll have to talk to your doctor about that. There are ways to help with that. Sometimes we give a little bit of insulin. Sometimes we say, can you wait to drink your coffee till later to help not raise that dawn phenomenon so much. All right, there's our little picture again. What affects my pre-meal blood sugars? So those are the meals before breakfast, lunch, and dinner. Pre-meal is also called preprandial. Sometimes you'll hear that and be like, prandial, what's that? That just means fancy way of saying meal. So what you ate the meal before. So for breakfast, let's say you had a pancake. At lunch, your blood sugar is going to be high because of that pancake you ate. Let's say you had, yogurt and berries for breakfast, your blood sugar is probably not going to be as high for lunch. So your lunchtime blood sugar is a result of what you had for breakfast. Your dinner time blood sugar is a result of what you had for lunch. Sometimes, let's say you had a low blood sugar between lunch and dinner. That low blood sugar, if you ate 4 gummy bears to treat that low blood sugar, your sugar before dinner might be a little bit higher. If you ate a candy bar to treat that low blood sugar between lunch and dinner, your blood sugar is really going to be high at dinner time, okay? Sometimes I'll say, well, I see all these lows between lunch and dinner at this time every day of the week. What are you doing? And a lot of patients will say, I'm exercising. So you use the monitoring of your sugar to figure out, what you can do and how to modify things. Stress levels can affect your sugar. What does your job entail? Do you sit at a desk all day? Are you up moving around? And then the last thing that can affect your sugars throughout the day is pain. That can affect your sugars too. So pain and stress are some of the ones that we can't, stress we can try to modify, but sometimes we can't. And pain too, that can elevate your sugars. Infection, I did not put infection on there, but that can too. All right. When a patient comes to clinic, we do something called a 24-hour recall. And it's where I take their continuous glucose monitor, I take their finger sticks, and we go through this painstakingly most of the time. So I say, okay, we're going to go through yesterday. So yesterday was Friday. You woke up at what time? I say 7:30. Why do you care? I care because I have to look at your sugars throughout the day. I want to see the pattern. So we look at what time you woke up, what you had to eat and drink, what your next meal was. So I want you to think of each of these things throughout the day and be able to use that at home to say, okay, she said that if I exercised at this time, it'll help to bring my sugars down. So I'll give you an example. Let's say after dinner, you always have a spike after dinner. It's going to be nice soon. It's going to be spring. If you have the ability to go outside and walk, that will naturally lower your sugars too. So you'll be ready to go to bed with a good blood sugar and wake up with a good blood sugar. All right, there's our little graph just for that burn. I'm going to burn that memory into your brain today. Okay, now we're at our crossroads again. I have one slide on medication, and that was intentional because there are so many medicines for diabetes. We're getting more and more medicines all the time. It's a conversation that you need to have with your doctor. But what medication you're started on depends on your A1C level. What fits into your lifestyle. So I have an issue sometimes where patients will say, okay, I saw so-and-so, and they said, do all of this, and I didn't do any of it. I said, well, okay, why didn't you do it? It's because, they can't do it. They can't give insulin at their job. Some of my patients work in prison systems. They can't take their insulin pens in. I need to know about that to be able to treat you. So I'm not going to throw medicines at you if you aren't going to take them or they don't fit into your lifestyle. So you need to have that conversation. Like, I don't think I can take that medicine if it's going to make me pee all the time because I won't be able to leave my house. So think about those things when you're presented with a treatment plan and say, how's this actually going to work? And then what are your goals? So if your goal is to not be on diabetes medications, fair. If your A1C is 10 and you still say, tell me, I'm not going to be on diabetes medications, we're going to work through it. We'll see each other every month. We'll be keeping an eye on you. But, the first rule is do no harm. So you have to figure out how to work that in your lifestyle. And then what comorbid conditions? Comorbid means basically, do you have any other health conditions like kidney disease and heart disease? I think I'm going over my time, right? No? Okay. Tell me how many minutes.
About 5.
Okay. All right. Sorry. I feel like I could keep talking all day. You should have gave me more time. Okay. Complications of diabetes. We're almost done. There are lots of complications of diabetes. That's why you have to take control. So we worry about heart disease and your stroke with diabetes, kidney disease, eye disease, neuropathy, foot complications, and gum disease. So really quickly, cardiovascular disease. What do I mean by that? That's heart disease. How are we going to lower your risk of heart disease? When you get your blood drawn every year and you see your cholesterol panel, there's 3 main things I want you to look at. Your triglycerides, your HDL cholesterol, and your LDL cholesterol. HDL is good cholesterol that protects your heart. LDL is bad cholesterol. We don't want that high. We want your HDL high to protect your heart. The only way you can help your HDL cholesterol is with exercise. LDL cholesterol, we want to get that down to decrease your risk of heart attack and stroke. Your doctor will offer you a statin. I think that's a trigger word for some people because you're like, oh, statins are going to make me cause me to have muscle cramps. Statins are medications for patients with diabetes that do lower the risk of heart attack and stroke. So next, if you smoke, stop it. Don't do it. It's not worth it. That's a modifiable risk factor. So we can modify things. And then weight loss. So all the things we talked about, exercise and diet, are to help us lose weight and take control of our diabetes. There's different goals for blood pressure. So make sure you ask your doctor, what's my blood pressure goal? What should my blood pressure be? Because there are different goals for blood pressure. This slide is so overwhelming, but I included it for you for later on. So when we talk about diabetic kidney disease, there's two things when you get your labs done. There's a urine test called a urine micro test. It's like to test small particles of protein in your urine that you can get with diabetes. And that's the first sign that the kidneys are starting to suffer from diabetes. So you should have that done once a year. And then there's something called a GFR number that's reported on your labs. How many people look at their labs after they're done? Good. Okay. So you can take these tools and say, okay, this is my GFR number, this is my urine protein number. Are these numbers good? Because you should know that. Sometimes I'll get patients, I'll say, oh, you have kidney disease. And they'll say, no, that's news to me. You have to ask about these numbers if you're not being told. You should be being told about these. How do you prevent diabetic kidney disease, blood pressure, and blood sugar control? Retinopathy. How many people know what retinopathy is? Good. So retinopathy, the small blood vessels in the eyes can be affected by the sugar. You should have a yearly eye exam, even if you're not having vision issues. Retinopathy is bleeding of these blood vessels due to high sugars, which can cause macular edema. The macula in your eye is your central vision. To save your vision from diabetes, you can have these little blood vessels kind of zapped with the laser. I know it sounds horrible if it happens, but we're going to prevent it from happening because you're going to get your eye exam every year. So you need to see the eye exam or the ophthalmologist for a retinal scan, and good blood pressure and blood sugar control can prevent it. Your feet, I know I'm almost out of time. I am out of time. Your feet, you have to look at them. You have to. And your weird endocrinologist will take a little thing called a monofilament, and she'll touch your feet with his monofilament. You're like, what is she doing? Doesn't make any sense to me. I'm testing the small nerve endings in your feet to make sure you can still feel them. A podiatrist is a good resource. If you can't, it sounds weird, if you can't clip your toenails, you have to have somebody who will, because you will get a diabetic foot infection if you let your toenails be overgrown. Okay. Last slide, myths and pearls. The myth is, these are my myths and pearls that I want to share with you. Once you start insulin, you can't get off. That's a myth. You can. The happiest day in clinic is when I can get someone off of insulin because they've modified their diet and their lifestyle and they started exercising. Your doctor is going to be mad at you because of your blood sugar control, so you skip your visit. If they are, you should find a new doctor because they are not going to help you. My doctor friends are going to kill me. But that's true. I'm not mad at you if you have high sugars. I want to know why. I want to try to fix it. So go to your appointments. Metformin causes kidney problems. This is a big debate. It does not cause kidney problems. Metformin is our only insulin sensitizer. It makes you more sensitive to your insulin. But if you have kidney problems, your metformin dose will have to be adjusted. Insulin will cause you to gain weight. That is true in certain circumstances. If you say, I can eat a cookie because I'm on insulin, I'll just take more insulin, you're going to gain weight over time if you don't modify your diet. So it all goes hand in hand. Get to know your numbers and ask why. Be your own advocate. Okay, I'm here. I don't want to do any harm to you. I love to take care of my patients, but you have to be an advocate and ask, oh, what do my sugars mean? Do I have kidney disease? Who should I be seeing? What should I do? So I hope that your journey is in the countryside, not in LA, on the freeway. But thanks for letting me talk to you. I only went 5 minutes over. Okay. All right. Good. All right. Thank you.